Thank you so much. Hi, everyone. My name is Jessica. I'm a nurse practitioner at Cleveland Clinic. I work in mostly inpatient GI and hepatology. I am coming up on 10 years in GI specifically in the next couple months. And so I'm excited to be here with you today. This can be very informal, so feel free just to kind of interrupt me and ask questions. I won't be able to see you while I'm presenting, so please just come off mute and interrupt me if there's any questions. Today, we're going to be talking about F3. Oh, my slide is not advancing. Give me 1 second. Okay. Today, we're going to be talking about comparing a patient with F3 fibrosis to a patient with F4 fibrosis, what that looks like, what our treatments would be, and the implications of those two different stages. Okay, I can always swing back to this at the end. Let me just move this because it may not work if it's there. I can always swing back to this slide at the end, but if you want, you can grab your camera on your phone now and scan the QR code to get the link to record your attendance for the meeting. Just pause for a second. And then there's actually another QR code. Again, I can come back to both of these at the end, but this is just a link to our GAP, MASLD and MASH community network. So you can see other Madrigal MASH disease state education and Madrigal Resdifra promotional programs. I can swing back to both of these at the end. Okay, so we're going to be talking through two different cases, more of a problem-based learning setup today. So our first patient, he's a 55-year-old Caucasian male. His BMI is 33, which is a little bit elevated. He was referred to your clinic for mildly abnormal transaminase levels with an abdominal ultrasound showing some increased liver echogenicity. And his only complaint is fatigue. So you may be aware liver disease commonly does not have any symptoms, but one of the symptoms that we do commonly see is fatigue, which is always just challenging because the differential diagnosis for fatigue is so large, but fatty liver can definitely be a cause of fatigue. So appropriate that that is what his symptom is. His medical history, he has a lot of the metabolic syndrome. So he is a type 2 diabetic. He has hypertension, hyperlipidemia, sleep apnea. Important to note that he does not use excess alcohol because that may put him into a different category if he was drinking. On physical exam, he has an obese abdomen. So we know central adiposity or holding your weight in the abdominal region is associated with metabolic syndrome and insulin resistance. He doesn't have any stigmata of advanced liver disease. So things that, I typically look for are jaundice, caput medusa across the belly or those large varicose looking veins, hepatosplenomegaly, things like that. Medications all seem very appropriate for his past medical history. So he's on lisinopril, which has that kidney protection and blood pressure control for patients with diabetes. He's on two medications, rosuvastatin and ezetimibe for his cholesterol and dapagliflozin for his diabetes. And here are his labs and vital signs. So his vitals, I see a lot of cirrhotic patients in the hospital that have typically low blood pressures. So to me, his blood pressure does not look bad, but it is technically elevated, and he does have that hypertension diagnosis. Not febrile, his weight is 235, going along with that BMI of 33. His liver specific labs, so my eyes always go straight to the platelets. His platelets are actually normal, but they are kind of bordering on low normal. At my lab, 150 is low, so he's real close to the bottom. His ALT and AST are about 2 times the upper limit of normal. I don't see AST to ALT 2-to-1 ratio that would make me concerned about alcohol, so that's good. His ALK-Phos, this would be normal at my lab, as well as his T-Billy. And his hemoglobin is 7.1. Generally, we like people below, 7, closer to that 6.5 range, but 7.1 is not a terrible A1C by any means. Other pertinent labs, he has a normal creatinine, a normal INR. So again, with a normal INR, this is suggesting to me that he probably does not have advanced cirrhosis that would be affecting his clotting factors. His ferritin is a little bit elevated. This can be seen with inflammation, which patients can have with fatty liver. It's not to the point where I would typically think about getting a hemochromatosis lab, but it is a little bit elevated. Usually above 400 is kind of the upper end of normal. His ANA is 1 to 80. This is also technically a little bit elevated. About 15% of the population do have an elevated ANA for no explainable reason. So I wouldn't worry too much about that unless you had other factors making you wonder about autoimmune hepatitis. And then his anti-smooth muscle, which is a screening for autoimmune hepatitis, and his hepatitis C and B serologies were both negative. So the key points that I want to highlight on this slide are, he is overweight. His ALT and AST are not majorly elevated. They're about 2 times upper limit of normal. There's no ratio to suggest that he's drinking. Alk Phos is normal, so I'm not so worried about a biliary disease. T-bili platelets and INR are all normal, which is a good suggesting he probably does not have cirrhosis. His diabetes is pretty well controlled, doesn't seem to have excess iron overload, doesn't seem to have autoimmune hepatitis or viral hepatitis. So we always want to make sure, even if someone is presenting very much like fatty liver, like this patient, that we are checking for the other things, because people can have fatty liver plus autoimmune or fatty liver plus PBC. So we always want to make sure that we're not missing another diagnosis that may be contributing to their liver disease and may also need treatment itself. So after we have, our initial assessment, we want to think about what stage of fibrosis is this patient. So we're thinking he's probably fatty liver based on the data that we have. Now we want to know, how severe is his fibrosis? And if you're, just to go over the 4 tests that are mentioned here. So a FIB-4, this is a calculation you can do pretty easily. Some electronic medical records will do it for you, or you could even Google a FIB-4 calculator, and it helps you determine a fibrosis level. All that you need to do it is an AST, an ALT, and a platelet, and those are all usually pretty readily available, on a CBC, plus either a hepatic function panel or complete metabolic panel. FibroScan, on the external side, it seems very much like an ultrasound probe, slightly different, but it sends waves into the liver and then gives us back a stiffness score. The CAP score is the measure of how much fat is found when you do a FibroScan. And then the ELF blood test. This is a proprietary blood test that you can send out. Patients may have concerns with insurance coverage. That's definitely something that can be looked into. But again, it's a proprietary test that will give you a fibrosis score. Sorry, I'm trying to figure out how I can make this. There we go, out of our way. Perfect. Okay, so now that we're acclimated to the 4 tests, these are our patient's scores. So his FIB-4 is 3.1, which is right cusping on, still technically in the intermediate, or sometimes called indeterminate risk, and high risk. His FibroScan results, his KPA is 11, which does suggest F3 or significant fibrosis. His CAP score is 262, which is in the moderate steatosis. And then his ELF blood test is 9.9, which is just a hair over the threshold for severe fibrosis by ELF test. So what we can determine from our patient is he probably has, based on FIB-4 and FibroScan, it's looking, well, I should say FibroScan is looking like F3, and then ELF and FIB-4 are suggesting severe or more advanced fibrosis, and then CAP is kind of in a category of itself with that moderate fibrosis, or I'm sorry, moderate steatosis. So if this were your patient, and feel free to come off of mute, is there any further testing that you would want to get? Okay, who wants to get a liver biopsy? Or any other labs? So I think with him, we had a fairly comprehensive serologic workup for chronic liver diseases. And we have several non-invasive tests that suggest he has more advanced fibrosis. So I would feel comfortable staging him as F3. Another reason that I would feel comfortable with that is because he does not seem to have any features of portal hypertension or cirrhosis. Again, he didn't have any hepatosplenomegaly on exam. He didn't have features of advanced liver disease like caput medusa, and his T-billy, platelets, INR were all normal, which are kind of the things that I'm usually laser focused in on for cirrhosis. And so how would you treat and monitor this patient? What do you guys think? Does anyone want to prescribe medication? So for this patient, just going to go to the next slide. We definitely want to talk about lifestyle modifications. This is something that we're probably very familiar with. His diabetes is under pretty good control. It could probably be a hair better. We can talk to him about diet and weight loss and exercise. He should continue his statin for his lipid control. He should continue his blood pressure medications. We could consider some of the newer medications like the GLP-1s that can aid with both weight loss and A1C reduction. But we should really be thinking about starting Resmetirom or Resdifra. This is the first and only FDA-approved medication to help with fatty liver and potentially downstage fibrosis, and it is approved for F2 and F3. So this is our F3 patient who is over time at risk for pushing over to cirrhosis, and we have a therapy that we could potentially prescribe him to help reduce some of that fibrosis, reduce some of the fat, and hopefully prevent him from further disease progression. I do want to touch for a moment on HCC screening. So AASLD does recommend screening all patients with cirrhosis, all patients with hepatitis B, regardless of fibrosis status. And some would say also advanced fibrosis. EASL does actually recommend starting to screen for HCC with F3 fibrosis because there is an increased risk for HCC even with F3, albeit less than someone who's cirrhotic or F4, but it would be good measure to start him on the every 6-month HCC screening with an ultrasound. Any questions on management for him? All right, now we're going to imagine that we have this same patient. All of this information should be the same. We're still 55, a Caucasian male, BMI elevated, metabolic syndrome without excess alcohol, no features of advanced liver disease, and then hypertension, hyperlipidemia, and diabetes-directed medications. This time we're going to alter things just a little bit. I think his vitals are about the same. His weight and his BMI are the same. His AST, ALT, ALK phos are also the same. You will notice here his T-billy has bumped up just a smidge, 1.4. This, I believe, would be abnormal at my lab. I think about 1.3 is the cutoff. And now we have a new thrombocytopenia. So his platelets are 128, which again is probably below the threshold of normal, which is around 150. He still has diabetes that is pretty well, but not perfectly controlled. And now on his other labs, we see, his creatinine has a little bit of a bump to 1.3. He does still have a normal INR. We talked about the ferritin before. This is the same as the first example, so not too concerning, but it is definitely a little bit elevated. His ANA is a little high, again, at 1 to 80. Again, as I said before, about 15% of patients can have an elevated ANA for no attributable reason. And then his autoimmune and his chronic liver serologies were all negative. So this patient, I'm starting to think, Just naturally, I tend to go towards the platelets when I'm evaluating a liver patient. It's kind of a quick and dirty way to see, are they low or normal? So his would be concerning. And then we're also starting to see with his T-billy being up a little bit, potentially some liver dysfunction. He does still have a normal INR, which is good, and also now a little bit of renal insufficiency as well. So at first glance, I'm thinking, does this patient have cirrhosis? Now we're going to take a look at his non-invasive testing scores, or his NIT scores. So similar slide to before. His FIB4 is actually the same, so it's 3.11, which is again in that intermediate or indeterminate risk range. This time his KPA is very high, 21, so greater than 12.5 does indicate advanced fibrosis. His CAP score is in the moderate range, so medium amount of excess fat or steatosis. And then his ELF blood test is in the cirrhosis range with a score of 11.4. So I would be pretty confident 2 out of 3 of our markers here are showing advanced cirrhosis or advanced fibrosis, which is consistent with someone with thrombocytopenia, a little bit of bilirubin elevation, concerning for some more advanced liver disease. So for this patient, is there any other testing that you think would be helpful? Maybe think out, is this someone you would want to biopsy? Are there any other labs you would be interested in seeing? And I think, again, at the same example, I don't think there's anything else. I would feel pretty comfortable labeling this patient cirrhosis, likely from an etiology of fatty liver, and the stage would be F4 or cirrhosis. And then different treatment and monitoring for this patient. Any thoughts? Would anyone like to come off mute? Okay, everyone's being shy today. So for this patient, he's going to go into a new category of what I would consider typical cirrhosis treatment, right? So he needs an EGD to check for esophageal varices if he hasn't had one recently, and potentially band them if they're present. We can also think about considering a non-selective beta blocker for him. He needs ongoing monitoring for HCC, so that every 6-month right upper quadrant ultrasound to screen for any new or concerning lesions. We're of course going to still talk to him about diet, exercise, weight loss, and optimization of his diabetes, hypertension, and hyperlipidemia. And then we'll also want to be monitoring for things like development of ascites, development of hepatic encephalopathy, GI bleeds, maintaining good protein intake, all of those things that come with our more advanced patients that fall into that cirrhosis bucket and need a little bit closer monitoring. So to compare and contrast the two patients, our first patient, which we're labeling as 6A, they had, and 6B, they both had the same FIB4 score. The ELF scores were different, so 9.9 on the first patient and 11.4, which is just over that severe or cirrhosis threshold. Their FibroScans were very different. So the first patient had a KPA of 11, which puts them into the F3 range. The second patient had 21, which definitely puts them into the advanced fibrosis or cirrhosis stage. Similar CAPs, both indicating moderate steatosis. So how do these two patients compare in management? So we talked about them kind of separately. Both patients should get diet and lifestyle intervention, optimization of their metabolic risks, such as diabetes, hyperlipidemia, hypertension, obesity. Both patients should be started on every 6-month right upper quadrant ultrasounds to screen for HCC. The difference here is that the patient with F3 is a candidate for Resmetirom or Resmetirom, which can help decrease fibrosis level and decrease fat in the liver and hopefully halt their liver disease progression so that they do not advance to more advanced fibrosis or cirrhosis. The second patient, on the other hand, is no longer a candidate for that medication because it's only approved for F2 and F3 fibrosis. And now he's in that grouping of having cirrhosis or advanced liver disease, advanced liver fibrosis. And so he needs to go into that screening category where we're thinking about things like portal hypertension, potentially the presence of esophageal varices. He doesn't now, but could he develop hepatic encephalopathy? Could he develop ascites? Could he have a GI bleed? All of these things that we need to monitor for. So his treatment and management is going to be different. Staging between F3 and F4, which non-invasive tests do you typically use to differentiate? I know in our clinic, we have a FibroScan right in clinic, so it's very easy to get that done. The only preparation is no eating and drinking for 3 hours prior, so we try to get patients in the same day as their appointment if we can, and they've been fasting long enough. Fib4 is also very easy to calculate, and again, you just need a CBC and then either a hepatic function panel or a complete metabolic panel to get the labs that you need for that. ELF is proprietary, so there could be some issues with insurance coverage. And it's typically a send-out lab, but something to look into and see if you can use it. And then if you have indeterminate or discrepant NITs, so say one of your NITs is looking like fibrosis and another is looking like F1 or F2, how do you kind of break that, or how do you make sense of that? So these are the patients where you may want to consider a biopsy or potentially another kind of NIT. And this is all in addition to your clinical evaluation and the patient presentation. So do their labs indicate advanced cirrhosis or portal hypertension, such as that low platelet, the elevated bilirubin, the elevated INR, or do the labs look more like our first patient where they have normal platelets, normal bilirubin, normal INR, and they're not looking so much like they're in that cirrhosis category. So you have to look at the whole picture, but if you have NITs that are indeterminate or two tests that are giving you a different fibrosis stage, you do want to at least think about whether you want to biopsy that patient to get some clarification. And then why is HCC surveillance important? So we know that hepatocellular carcinoma occurs mostly in patients that have cirrhosis. It is very rare for somebody to get hepatocellular carcinoma without having advanced liver disease or hepatitis B. But we also know that our F3s are at risk, and EASL does recommend screening them as well. So screening every 6 months with that right upper quadrant ultrasound can be helpful to identify any lesions.